Anim, bonjour. Hello, everyone. Welcome to today's Ontario Health Team virtual peer sharing and learning session, primary care process of attachment. We're going to give everyone a few minutes to sign in before we start. So as we wait, please introduce yourself and your organization or OHT or PCN in the chat box, and make sure you select everyone from the dropdown so that we can all see who's joining. I've met many of you, but for those of you I haven't, my name is Leslie McGeough, and I'm a focal point and coach with RISE. We have many new people joining today. So for those of you who are not familiar with RISE, we are a free resource for Ontario health teams with the specific purpose of supporting them as they develop and mature. Mike Heinmarsh, our head coach, joining us from RISE. Greg Stevens from Muskoka, thank you for joining us today. In June and July, we shared with you a taxonomy of 9 approaches to primary care access and attachment. And today we're going to dive a bit deeper into a few of them. We'll focus on how to develop and optimize your own processes for attachment to foster ongoing relationships between a team of health providers and a client. You're going to hear some examples of this work, including from Lanark Leeds Grenville OHT, which will share their experiences building these processes. So I recognize that September is a busy month. We're going to actually shorten today's session to 60 minutes and try to end at 1. Given this, I am going to begin today's session, but please continue to introduce yourselves to one another in the chat box. So we'd like to begin today by recognizing that we're all joining from different places across what we now call Ontario, and that we're all located on traditional territory of the Indigenous peoples. As a RISE partner based in Mississauga, I'm using the Indigenous Traditional Land Acknowledgement Statement, which was developed by the Indigenous peoples in our region. As we meet here today, we're in solidarity with Indigenous peoples of Turtle Island. And we would like to begin by acknowledging that the land on which we gather is part of the treaty lands and the territory of the Mississaugas of the Credit, and before the traditional territory of the Haudenosaunee, Huron, and Wendat. We also acknowledge the many First Nations, Inuit, and Métis people who call this area their home. We're grateful for the opportunity to be working on this land. Land acknowledgements offer a moment to recognize the role of treaty making, appreciate the land on which we live, and the importance in learning from our Indigenous community members, applying it to our ways of living, working, and being together. On the slide here is a picture of the Credit Valley River, which I enjoy walking with my in-laws, especially in this unseasonably warm weather we've been lucky to have lately. I am thankful for those who've taken care of the land before me, and it's important to me that we continue to care for and preserve it. I also recognize the ongoing colonialism and racism against Indigenous peoples. And as a third-generation settler, I feel it's our responsibility to shed light on and address it. We've provided a link here for you so that you can learn more about treaties. Please take a look. Please take a moment to reflect on the Indigenous territory in your region. Right, I'm going to pass it over to our head coach, Mike Heinmarsh, to walk us through today's objectives.
So welcome, everyone. As Leslie hinted at earlier, the objectives for this session are to talk about attachment as a process and an outcome, but more importantly, how it really is a process for attaching patients to primary care, and how we think about how we can strengthen primary care is sort of the overall goal as we move forward. We also want to get some feedback from you in terms of how we're thinking about adapting our programs to better support the OHTs, so we'll be doing that at the end. But what I want to do is I want to begin with an acknowledgement of all the work that the OHTs have been doing. So if we can go to the next slide. You'll probably remember this slide if you've been with us for a while, but in the last 6 years, your job has been to take the chaos that is on the left there of our current system, where people are siloed, referrals are not necessarily efficient, but basically the system is somewhat chaotic. And to create an integrated care system with whole person equitable care as the founding principle, but more importantly, primary care is at the center of this work with the patients obviously in primary care. So let's go to the next slide. So in building this system, we really need to start focusing, and not start focusing, you've been doing this work, but we need to focus on primary care and make sure that we understand that it's at the heart of all of this integration work. Primary care is a care coordinator for bringing all of the community providers and other service providers together in a way that makes sure that no matter where the patient touches the system, everyone knows what's going on with that patient. And then, as you've heard before, population health management is a critical process and outcome of a fully integrated system. So when we have an integrated system, we know that the population outcomes are improving. We know that everyone in the population is receiving equitable care and no one is left behind. Let's go to the next slide. Now, one of the things that I think is really important to acknowledge is for close to 6 years now, all of you have been working on this integration work. And we wanted to point out that your work is what is starting to build this high-performing primary care system. For you, it may have seemed chaotic over time, and you're working on this over here and that over there. But if we take a look at all of the work that you've done, it really is moving towards that high-performing primary care. In the months to come, we will work even more on in improving that primary care system. But what you see on the left here is all the work that you folks have been doing. You're working on attachment. You're working on access to care. You have incredible patient, family, caregiver engagement. All of you have been working on ALCs. You're now working on chronic disease prevention and management, and part of that work has been your integrated care pathways. You're building PCNs. You're expanding existing PCNs. Many of you have done tons of patient navigation work, creating service catalogs in the community. You've been training staff to be culturally sensitive to a variety of people that are either marginalized or have ethnic diversity. You're going to be, well, you have started working on the Healthcare Connect list to work that list down and attach people to primary care. ED diversion work, integration of home services, cancer screening, and interprofessional primary care. So we just wanted to point out that while this all may seem somewhat piecemeal in the past for you, it really is working towards that high-performing primary care, and you've all been working pretty hard. And so we just wanted to acknowledge the incredible work that all of you have been doing. I'll hand it over to Lori at this point.
Thanks, Mike. I'm Lori Zager. I'm one of the RISE coaches, and I think it's acknowledging it for sure, Mike, but it's also a round of applause for all the great work that has been done. I mean, it's very incredible. It's really incredible, all of the work that has been the progress in the last few years. So for those of you who were on the June RISE session, John talked about a taxonomy of 9 possible approaches to really improving primary care access and attachment. We're not going to go into each one of them today, but we're going to start to really drill down into a level that is pretty specific. It's pretty in the weeds, and it's when we start to look at attachment as a process. So next slide, please. So when we think about attachment, we often talk about it as an outcome. So if you think about when we talk about those 2 million Ontarians that will be attached by 2029, or we think about the work that you've been assigned to do around the Healthcare Connect waitlist and working that down, those are outcomes. But we also, and it's not one or the other, it's both, we also need to think about attachment as a process. We need to get into the weeds of what are the steps in the attachment process and who's going to do what, when, where. Why do we need to get into that level of detail? Because we need reliable processes. And what do reliable processes help us with? Well, they ensure consistency. So they make our system predictable. It decreases the variation within the care that we provide. So it's really important to have those reliable processes. It also leads to quality. So if you think about those 6 dimensions of quality that we always talk about, they're in the brackets there. By having a reliable process, it leads to our systems being more efficient and effective and timely and equitable and patient-centered and safe. So that's why it's important for us to get into the weeds around attachment. it also enables scalability. And I want to stop here and just acknowledge that all of you have been doing some really great work on attachment already, and we acknowledge that. We're not saying that you're at the starting point, but we've been hearing some great stories about the work you've been doing. We're going to hear another couple today, and we're going to hear from Morgan from LLG about the great work they're doing. But we can only share and scale those ideas and spread those ideas if we're really aware of the details of the steps in those process, and we can pass that off to each other and say, it's really important to pay attention to this. The other thing, attachment, there's a risk to it. We risk impacting the access in our centers. And so it's only when we really dig into the attachment and what we include in that process that we can start to address some of those risks that are inherent in attaching people to primary care. Next slide, please. So I'm going to talk about two examples of attachment and intake processes today, and then I'm going to flip it over to Morgan, who's going to talk about their work. The first one I'm going to talk about is Rideau Community Services, which is a CHC in Eastern Ontario, and I'm going to talk about their Better Health project. Then I'm going to flip over to Seaway Valley's intake project that they worked on in 2023, and you'll see some threads and some important elements in all of these three presentations. So starting with Rideau. The Better Health project is from a while ago, 2011, but it was a great example of work that was done in response to a crisis in the community where a couple of MDs retired, one passed away in a very short period of time, putting about 5,000 patients without a primary care provider. And while we are kind of like used to it now, back in 2011, unattached patients were really seen as a crisis. So Rideau, and this project was the brainchild of Peter McKenna, the then CEO, and he really wanted the CHC to respond to this community crisis. Next slide, please. So what did they do? They created a very intense intake process to attach the most in need. They couldn't attach 5,000 people, so they were trying to bring equity into it without destabilizing the CHC. And Peter heard loud and clear from his clinical team at the CHC that by them taking on a whole bunch of new clients, they were going to create chaos. So what they really tried to do was build this attachment process that was going to prevent the chaos in the CHC. They received one-time funding from the Southeast LHIN. It was an amazing collaboration between the hospital, the CCAC, and the primary care organization. And from the first meeting, the first planning meeting, in 2 months, they saw their first client. So they were really iterating quickly in terms of their improvements. Next slide, please. So what exactly did they do? They took this intense intake process for the purpose of attaching people to the CHC, and they tried to really stabilize all these clients or patients before they got to the CHC. The care was delivered by an interdisciplinary team. There was 2 nurse practitioners, or 1 full-time nurse practitioner, 2 part-time physicians, an RN, 2 part-time pharmacists. It was a husband and wife team that made up 1 full-time equivalent, social worker, and who also acted as a project manager. And then there was a planner and evaluator, and that was me. And I had the privilege of working in this project and with this amazing team. In terms of that first step of an attachment process, it's also where are these clients coming from? So that referral piece was really important. The clients for this project were identified by the hospital, the CCAC, and from those previous family practice offices that were closing. And they really tried to dig into the community to find those folks who were most at need. The care was delivered because it was a real quick turnaround. The care was delivered in group medical visits with one-to-one follow-ups with a strong emphasis on self-management. So really pulling those self-management principles into this work. Clients or patients were in the Better Health project for about 6 weeks, give or take a little bit. So this was quick. They received full assessment on their current health status. They received catch-up care, and they received any referrals that needed to go to other services. So it was only then, and Peter talked about, he wanted these folks wrapped up like with a bow before they were transferred into permanent primary care, because then it wouldn't have that negative impact on access to care. Next slide, please. This is a process map. So again, getting into the weeds of who does what, when, where. I'm not going to go through the details of this. If you're interested, please reach out to us. Happy to spend some time with you. But those three big bubbles were the group medical visits. So you can see that within those, vitals were taken, med reviews were done, vaccinations were done. So there was real medical care done, and then any reaching out to other parts of the system was done within these group medical visits. As a bit of feedback, we often hear that patients don't like group medical visits. If they didn't like it, they would have shown that with their feet and they wouldn't have continued. And we had almost 100% of group medical visit. Those who attended the first group medical visit go all the way through and attend all three. So it was received really well. Next slide, please. So what were the key lessons from this work from the Better Health Project? There were many, many. It's really amazing project. But three of them are, the first one being the power of the group medical visits. It enabled a large number of people to receive care in a very short period of time. And it also facilitated the extensive education and self-management pieces that were brought into this for clients. Really different focus for many of these patients in terms of getting that health promotion information. The impact of the pharmacist, Peter he knew his community. He knew that building pharmacy into the interprofessional care team was important. I don't think anybody knew how important. It's over 400 drug-related problems were identified, often tied to the social determinants of health and income. And then the team-based care really supported equitable care. The team rounds that were part of the process map really enabled a distribution of the clients both equitably to the center and making sure that they were receiving that care. Next slide, please. So just to give you an indication of some of the success, in the 6 months prior to admission to the Better Health Project, almost 73% of those clients visited the ED, resulting in 263 visits. In this, in the 6 months afterwards, after admission to the Better Health Project, 24% of the clients visited the ED, resulting in 55 visits. Now, any of you who are data geeks like myself, you're going to look at that chart and say, wait a minute, it actually was dropping before, because we zeroed everyone to their admission time. It was dropping before they were actually admitted. We went back to the hospital to learn about that. And that rise of people being unattached, a lot of those visits to the ED department were for prescription renewals. So they were going up and then they were dropping. What we predicted was that Mount Everest, would have been repeated every 3 or 4 months. And what we saw instead was that second mountain in that chart was much smaller, and we attributed that to the Better Health Project. Next slide, please. So now I'm going to jump into this onboarding and orientation improvement project, and the two are kind of connected. This is some great work led by Stephanie Hemrick and Kelly Lynch at Seaway Valley Community Health Center, another community health center in Eastern Ontario. Next slide, please. So this is an organization with a real culture for continuous improvement. They had participated in 3 learning collaboratives offered by the Alliance for Healthier Communities. And they worked the improvement work they did in the 3rd learning collaborative around improving access to primary care was to do a real deep dive into their orientation project. They had a nudge because they had a new provider starting. They wanted that new provider to be able to hit the road running, so they wanted to build up that person's panel in an efficient way before they started. Followed good QI principles, did lots of PDSA testing, they met frequently, they had a great team, and they did process mapping. Next slide, please. From their process mapping, they learned 2 things. One, that there was a lot of churn happening around paperwork at the beginning of their orientation process. People were going back and forth and chasing people for information. It was taking an awful lot of time. The second thing they learned, that their nursing orientation appointments were actually, they were spending nursing time on that chasing of that paperwork and not actually doing nursing work. So I was the coach for this team, and I shared that Better Health project with them. They knew they couldn't replicate every aspect of the Better Health, but they really liked the idea of the groups. So their change idea was a group orientation for completion of the paperwork and starting that care. Next slide, please. So here's their process map. Again, not going to go into the details, but they got very specific around who's going to do what, when, where. And they were able to improve their process continuously by having that level of detail. Next slide, please. So what were some of the results that were found in this? Prior to this group orientation process that they built, the registration forms were taking about 2 weeks for them to complete. In their new process, it took about 1 day because they had a captive audience. They had all the clients there. It was a face-to-face group orientation. Previously, they had about a 60% accuracy of completion of all the information they need, like social demographics, getting permissions signed or consents. Because they were face-to-face in a captive audience, the accuracy went up to 100%. So there was no need for that churn anymore. There was no need for the chasing down of this information. In terms of policies being delivered before, it was 20 minutes per client. You know, what's a CHC? What can you expect? What does team-based care look like? Just, you know, really preparing the clients and patients. After they did the group orientation, it was about 20 minutes for 10 to 20 clients. So huge efficiencies were gained within this work. The time for the nursing appointments were still 40 minutes per client, but all of a sudden the nurse was actually doing nursing. She was starting to work to the full scope of her practice instead of doing paperwork. The average time from registration to first appointment went from 3 to 4 months down to 2 weeks. And the average number of clients per week went from 1 to 3 up to 10. Now, they created some unintended consequences. They created a real nursing, a real bottleneck at the nursing orientations, but they started to work on that too. But they really felt that this group, leaning towards the groups, was a great way for them to be able to be efficient. So now I'm going to turn it over to Morgan, and she's going to continue this thread on the great work that they're doing there.
Thanks, Lori. I don't have slides to share. I'm just going to have a more informal conversation to outline the work that we've done in Lanark, Leeds, and Grenville with our small but mighty team here. And just to set the stage a bit, coming from primary care myself, where I had previously worked in a community health center for 15 years, I come with a very big passion about supporting and collaborating with our partners to be able to develop truly a sustainable, equitable approach to connecting people with primary care and other supports and resources as needed. So this work that I'm going to speak around our intake coordination role that we piloted back in 2022. This dates back to a time where the OHTs were a little bit less stable in terms of funding. And so this was a really great opportunity at the time, and we spun it up fairly quick. It was a pilot over approximately 6 months. About 3 months was the development of some of the processes, and then around 3 months from January to March, really connecting with the patients and doing the intake and needs assessment component. So we did pilot this intake coordinator role, whereby we developed an intensive intake process. And that process would occur prior to the attachment of a patient to a primary care provider or team, with a specific focus on those who are unattached and those with complex health and social needs. This was coupled with a few other pilot projects that were happening simultaneously within the OHT. One was an emergency department identification and hospital identification of unattached patients. So when those patients were there and they themselves identified as unattached and wishing to be connected to primary care. As well, we had a pilot with nurse practitioner services to provide interim care supports to those identified unattached people going through this intake process. So the process was tested on a small scale and refined through real-time feedback and collaboration with community partners participating. Really, the intention was to design this process to help relieve some of that burden on primary care providers specifically, to onboard patients. And I reflect back to what Lori mentioned about the Better Health Project, about wrapping it up with a bow. Those patients were sort of teed up in a way that it was a smoother transition for primary care providers to attach them. So by completing nursing intakes and assessments, gathering clinical data from various digital sources, and coordinating referrals and navigating the patients to other appropriate resources. Clients were identified through a few inputs, so emergency departments, the hospitals, those specifically identified as unattached. Referrals would come through community partners such as the community paramedics or other community support agencies. And as well, our intake coordinator collaborated directly with Healthcare Connect care connectors at the time to work through identifying those on their list. So once the patients were identified, the intake coordinator would conduct that intake and needs assessment either in person or by telephone. And there were a few digital tools specifically that they would leverage, such as Connecting Ontario and SHIP and Ocean e-referral. So that was used to really build that chart per se for that patient to give an understanding of where they had other touch points in the healthcare system. So the client or patient would be routed for catch-up care with either the nurse practitioner, which was the other pilot project at the time, for preventative cancer screenings, any referrals that needed to be made, as well as other allied healthcare professionals, mental health, respiratory therapy, other regional programs that we have in our area for lung health coordination and diabetic education programs. So the intake coordinator would make any referrals that they could make to the appropriate supports, including those that would address those social determinants of health. And the clients would be attached to a primary care provider when they were matched and it was available, and they would have that nurse practitioner support in the interim. And so moving forward, we are learning to leverage some of the successes and strengths of that pilot that we gleaned. So that coordinated connection point to primary care providers and the referrals to the community resources and services was a huge highlight and really helped patients have those wraparound supports in place that could be attended to and didn't need to have a primary care provider initiating the provider engagement. So we had some preference noted by some of the providers to work with the intake coordinator because of the communication and the direct coordination. There was the warm handoffs and the collaborative communication with the primary care teams that made it a little bit smoother for the patients and for the primary care teams accepting them. Leveraging the different data health sources through those digital tools I mentioned really helped to capture some of the social needs and through that deeper intake assessment. So the impact was between January and March, 206 residents were attached to, patients were attached to a primary care. Some of the challenges and areas for improvement that we've learned. At the time, there was no direct charting in any of the primary care providers' EMR by the intake coordinator. So those manual workflows were done by paper and tracking was on paper, and that was quite onerous and a lot of work and time consuming. So something that our team is currently exploring options on how to address this moving forward. Provider buy-in. So there was, I think, less of an understanding of the OHT goals, but I think we are in a different landscape now that we have the PCAT mandate around access and attachment. There's a lot of information going around and shared goals around getting Ontarians access and attachment to primary care. The data gaps at the time, there was inconsistent reporting and data as nurse practitioner roles and some of that sociodemographic data was underrepresented. Since 2022, I think we have improved some of that information that is available to us, which is great. There were client barriers or patient barriers, so some of those digital limitations, and really noted that one of the big gaps was that there wasn't a true way to identify the social complexity, and there was no way to really triage that or a system to prioritize that. So as we are taking our lessons learned from our previous pilot and moving now, we're looking to expand this model to more communities and providers in our OHT. And so marrying up some of the work that we've done more recently, which is around refining the intake process itself. We've engaged in extensive process mapping exercises around the intake procedures with the various primary care models to understand what their current practices are, and where we might be able to come up with some recommendations to support an equitable approach. We're also developing and testing some standardized intake forms that include specifically social determinants of health and screening to improve that matching and improve the routing to other community and allied health supports in the interim. We will be further exploring what onboarding supports would be needed for patients and clients entering primary care practices to ensure a smoother supported transition. As really ultimately the goal of our work is to create, as I mentioned, a sustainable, equitable intake, attachment, and access plan across our OHT region. So I'll flip this back to you, Lori. Thank you for that opportunity to share.
Yeah, thanks so much, Morgan. I think it's the work that's being done at LLG is such a great example of getting into the weeds to be able to create those efficiencies and get clients into care. Maybe next slide, please. So just to wrap this piece up, we're going to move into a Q&A. I know there's some questions in the chat that we'll get to for sure. We can talk about those, but just to finish this off, I wanted to ask a couple of questions of you. Again, acknowledging that many of you are already working on attachment, you're already well on your way, but can you just take, can this type of work, if you reflect back, for those of you who are already working, is it reflecting now to look for improvement opportunities? Can this type of process work, really getting into the weeds of process mapping, support attachment in your OHT? Do you need to circle back? Do you need to get into the weeds? Or if you're at the early parts of your journey, can this type of work be helpful? And how can you involve your PCN in this type of work? Or can this type of process work help with your continued development of your PCA and PCN if you engage them in this process type work? Some next steps, possible next steps for your consideration. Would mapping help with your attachment process? Would identifying the who does what, when, where type exercise really create clarity among all of you and your partners around who's doing what with respect to attachment? And then analyzing that process map together, really talking about where are bottlenecks, where is the variation that is not helping with our system, where are those duplications within our system so that we can start to create those efficiencies. So just trying to think of where you're at on your attachment journey and kind of reflecting again on what we've talked about today. And the RISE coaches are here to help. Please reach out to us anytime. We're happy to come and talk to you about this kind of stuff in more detail.